Good evening, everyone, and welcome to tonight's Ostomy Canada webinar on Living Well with an Ostomy, Tackling Common Complications. My name's Troy, and I'm on the Board of Directors for Ostomy Canada, and it's great to have you on again for this quarter's webinar. While I go over some housekeeping items and do some friendly introductions, I'll invite our guest speakers to pull up their slides. Tonight's webinar is proudly sponsored by Hollister, and we want to sincerely thank them for their support in making today's program possible, but also for their ongoing support for ostomy care and ostomy support. Living with an ostomy can come with unique physical and emotional challenges, and tonight's session is designed to provide practical, supportive, and evidence-based guidance for individuals with an ostomy, their caregivers, healthcare professionals, friends, family alike. And our presenters will focus on or discuss common ostomy-related complications from skin irritation and leakage to parastomal hernias, and also sharing some real-world strategies to improve comfort, confidence, and quality of life. Before I get to our special introductions, I wanted to remind everyone that we're recording today's webinar. So if you have to head out a little bit early, or if there's someone in your network, maybe it's a friend or family member that would benefit from watching today's webinar, you'll be able to access that online on our ostomycanada.ca website, along with our other past webinars too. We also wanted to thank everyone who had submitted questions in advance. We got so many that came in, which is fantastic to see. Quite a few of them we hope are going to be answered from this presentation. And for some of them that maybe aren't, we have grouped them thematically and are going to do our best to get to as many questions as possible at the end of today's webinar as well. And so on that note, I really wanted to introduce our guest speakers and thank them for being with us today. Firstly, it's my pleasure to introduce Dr. David Yu, who's a colorectal and general surgeon practicing at Peterborough Regional Health Center and the Peterborough Clinic. He specializes in the surgical management of colorectal diseases, including colorectal cancer, inflammatory bowel disease, benign anorectal conditions, and complex abdominal pathology. His expertise includes minimally invasive, laparoscopic, robotic, and transanal surgical techniques. Dr. Yu completed his medical degree in general surgery residency at Queen's University, followed by a colorectal surgery fellowship at Advent Health. He also holds a Master of Public Health from Johns Hopkins Bloomberg School of Public Health, with a focus on epidemiologic and biostatistical methods for clinical research. I'm glad you did that and not me, because I wouldn't have been able to pronounce it properly. His academic and clinical interests include surgical outcomes, colorectal cancer care, and advancing minimally invasive approaches to improve patient care. So thank you for being with us today, Dr. Yu. And I'm also happy to introduce our next speaker, who is Katie Jones. Katie is a nurse specialized in wound ostomy and continence, or NSWOC as we call them, with extensive experience across both acute care and community healthcare settings. She brings a strong background in ostomy management, wound care, and patient education, supporting people with complex and chronic conditions. Katie's also involved deeply in educating and mentoring healthcare professionals on evidence-based practice and patient-centered care. She's passionate about improving quality of life through education, collaboration, and practical support strategies for individuals living with an ostomy. So thank you as well for joining us this evening, and we're in great hands with the both of you. So whenever you're ready, you can pull up your slides there, and I'll hand over both the mic and the slides to you. Thanks so much.
Hey, all right, good evening, everyone. Now you should be able to see my screen, so I'm going to start my slides here. All right, so this is just kind of the basic agenda that we're going to kind of follow for the rest of the talk. I'll start off with a quick introduction, some very basic anatomy and physiology, and then we're going to do some introduction to the anatomy of ostomies, types, and kind of the function of ostomies, and then we kind of will wrap up with some common complications of ostomies, specifically talking about high output, dehydration, leaks, skin breakdown, excoriation, mucocutaneous separation, and then prolapse and parastomal hernias. And then we'll have some question for Q&As afterwards. All right, so maybe before we start, I just want to add in a little disclaimer here, because this the presentation is meant to be a very general educational overview, for the lay person to better understand how ostomies work and why these complications happen. Now, because we're talking about, to a very broad audience from across the country, there are very, very different practice patterns depending on where you are located and what kind of access you have to kind of specialists, NSWOCs, and things like that. So please remember that even the terminology and treatment options and availability and access to specialists will vary depending on where you are and what your local practice patterns are. So this is not in kind of an end-all and be-all, but rather just a very brief and general introduction to kind of the world of ostomies. So we'll start off with a quick introduction on what exactly is colorectal surgery. And like Troy said, I'm a subspecialty in colorectal surgery, which is a subspecialty of general surgery. But basically, the field of colorectal surgery specializes in both benign and malignant conditions of the colon, rectum, and anus. So for things like benign conditions, we deal with diverticulitis, inflammatory bowel disease, fecal incontinence, pelvic floor disorders, and then as hemorrhoids and fissures. And then, of course, for the malignant side of things, we're looking at colorectal cancer, anal cancer, and certainly appendiceal cancer as well. And I also have the privilege of working with Katie, who is our nurse specializing in wound and ostomy care and continence here at the Peterborough Hospital. And as Troy has mentioned, she is a nurse that basically subspecializes in the field of wound and ostomy care. And someone like Katie has very advanced and specialized skills in this area, and Katie works very closely with myself as well as lots of other people at our hospital and patients and their families to address concerns based on the individual, right? And so, when we're talking about ostomies and medicine in general, there's no one size fits all, and that's where Katie comes in with her specialized knowledge. And she uses this knowledge kind of to tailor solutions based on the individual and the individual patient. And our nurses that specialize in wound and ostomy care, they can work in hospitals, in the community, in nursing homes, and private agencies as well. All right, so with that out of the way, we'll go on to some anatomy and physiology. So this is a very, very brief and basic anatomy and physiology. So kind of when we're looking at the digestive tract, we start from the mouth and kind of work our way down into the rectum and anus. But we're specifically going to focus on small bowel and large bowel. So the small intestine is basically what's connected to the stomach. And it's about 3 to 5 meters in length, depending on the individual. There are typically 3 segments: duodenum, jejunum, and ileum. So basically from the top, it goes duodenum, and then jejunum, and then ileum. The main function of the small bowel is really to absorb electrolytes, macronutrients, and micronutrients. And then as we work our way down the digestive tract, the small bowel is then connected to the large bowel or the enlarged intestine or the colon, which is typically about 1 meter in length. And we kind of divide this into 4 segments. So the first segment is the cecum, and then the ascending or the right side colon, transverse colon, and the descending or the left colon, and the sigmoid colon. And so this is a little bit different because we're not quite to the rectum yet, but the main job of the colon is to absorb electrolytes and to absorb water as well. So it's very important in basically solidifying the food that's passed into the colon from the small bowel, basically reabsorbing the water so that we don't get dehydrated. And then as we work our way further down, we get into the rectum, which is typically about 15 centimeters in length. And then we further divide this into upper, middle, and lower. And the main function of the rectum is really to function as a reservoir for the stool. And the very last part is the anus. And this is kind of the muscular ring, or what we call a sphincter. And really the main control here is to control defecation and control having a bowel movement. All right. So we'll kind of switch gears into introduction to ostomy. So the term ostomy comes from where what it means is that it's a creation of an artificial opening via surgery, and the stoma is the actual opening created by ostomy surgery. And I think a lot of you are probably already aware at this point that, you know, for when we use ostomies and stomas, they're almost interchangeable. So, you know, you may hear us refer to one or the other, and for our purposes, they kind of refer to the same thing. So this is how we make an ostomy or a stoma during surgery. And so what we're doing is that we're pulling this piece of bowel through the abdominal wall, which is kind of the muscle that's sitting in the middle of your belly. And after the bowel is pulled through the wall, what we do is we brook or evert the bowel. And this is very crucial for small bowel. And we'll get to that into a little bit later into this presentation and why that's important. But basically, we turn the bowel inside out so that it rests about 1 to 2 centimeters above the skin level. And again, it's very, very important for small bowel ostomies. And there are also lots of different types of ostomies that we can make, depending on what we're pulling through the skin and the abdominal wall. So there are ileostomies, which are probably one of the most common ones. So this is the terminal ileum, or the last part of the small bowel. It's usually situated in the right lower quadrant of your abdomen. And then the next most common type of ostomy is probably a colostomy. And so this is where we pull out a piece of colon through the abdominal wall. And so the most common type of colostomy is probably a sigmoid colostomy, and it's usually situated in the left lower quadrant of the abdomen. And so as the name suggests, it's the sigmoid colon that we're pulling through. Sometimes we do transverse colons as a transverse colostomy, and that will usually be situated in the upper abdomen. More rarely do we get into pulling out a piece of jejunum or making a jejunostomy. And this location can be variable, but usually we try and make it in the right lower quadrant as well. And then there are kind of the other ostomies that you may have heard of or encountered, where we bring out a piece of small bowel through the skin, but we join the ureters to the small bowel, and so we call that a urostomy. So instead of stool coming through there, there's urine that comes through, and it's usually for patients that have had bladder surgery for a bladder tumor or other reasons. But it looks similar to an ileostomy and usually sits in the right lower quadrant as well. So when we're looking at ostomies, there are lots of different types of ostomies we can make as well. So there are loops and ends and mucus fistula and double barrel. So kind of there's a lot of different varieties. And one of the more common ones is a loop ostomy. So if we're looking at a cross section of what that looks like, the piece of bowel that comes through the skin goes up through the abdominal wall. And so there's an opening here, and then it goes down again. And there's a separate opening here. So it looks like this when we're looking at it from the outside. So you can see one end and a second end. And the benefit of this is because there's a piece of, there's a loop of bowel that comes out through the abdominal wall, it's much easier to reverse at a later surgery if it's possible to reverse it and if you wish to have it reversed. And then the next most common type of ostomy would be an end ostomy. So instead of that piece of bowel being connected, one end gets put back inside the belly. So one side comes out through the skin, and basically that forms the ostomy itself. And then there's another end that's usually stapled off, sitting somewhere in the abdomen. And so it looks like this. So we have one opening or one lumen of the skin, and this one is more difficult to reverse down the road because in order to reverse it, we have to find the other end in the abdomen rather than doing everything on the outside through the skin. And then there's a bit of an uncommon one, which is an endostomy plus a mucus fistula. So you have one opening as the opening of the ostomy. Then you have usually typically a smaller opening elsewhere in the skin, and this can be put basically anywhere. But what comes out there is basically mucus that the inside of the bowel is still producing. And then an even less common is what we call a double barrel, where there's two lumens that comes out through the skin. Again, they can be beside each other or in two different locations. These aren't very commonly done, but they are still easier to reverse because you can have both ends right at the opening of the skin when we are reversing this. And so then we can get into kind of the types and functions. So the probably the most common ostomy we make is a loop ileostomy. So as the name suggests, it looks like a loop and it looks like this. And it is the terminal ileum that comes out through the skin. And typically what we use this for is to protect what we call high risk anastomosis. So the most common reason I do this in my practice would be for either a colon cancer that is at risk for leaking. So basically the first surgery is to remove, whatever part of the colon we're trying to remove, join the colon together. But because that connection is at a higher risk of a leak, we bring out a loop ileostomy like this so that it diverts the stool away from the inside of the colon, allows it to heal, and then we reverse this ileostomy with another surgery down the road. And then there's the next common one, most common one is probably a loop colostomy, and it's usually what happens is that's when we bring out a loop of colon through the skin, and it's usually to relieve a distal obstruction. So what that means that you can have an obstruction, and the most common obstruction is usually a rectal cancer or an anal cancer. And so you have an obstruction, further down, and there's stool kind of building back up. And so we bring out a piece of colon here so that the stool doesn't have to go through the rectum and through the anus. So that relieves the obstruction while we kind of figure out a more cohesive and comprehensive treatment plan. And again, this can potentially be reversed as well. And then the next one is what we call an end ileostomy. So this basically is just a loop of terminal ileum that comes out through the skin. There may be another end of bowel sitting somewhere else in the belly. There may not be. It just all depends on the clinical situation. This is more so commonly done in kind of the emergent setting where the patient's quite sick. We don't have a lot of time, and all we're trying to do is basically get them off the OR table. And then there's also an end colostomy. Again, this is more so commonly done in the urgent or the emergent setting. And the most common reason why we do this is usually a perforation in the colon for whatever reason. And so as you can see here, there's a piece of colon that comes out through the skin, and then there's a little stump of the rectum that's disconnected and it's kind of sitting in the pelvis. And this one is typically the one that we find most difficult to reverse. Number one, because of the fact that it was an emergency surgery in the first place. Number two is the anatomy of the pelvis can be challenging to work with, depending on the patient. All right, so we're going to switch gears and kind of move on to some of the more common ostomy complications, and I think a lot of you are already aware of this. So certainly the most common complication we deal with is high output or dehydration, and it's one of the most common complications we see in small bowel ostomies. And for someone with a jejunostomy, they're at much higher risk of getting dehydrated and having high output from their stoma. And so the more proximal the ostomy, so higher up on the digestive tract, like the higher up it is on the digestive tract, the higher somebody is at risk for getting dehydrated. It can also happen after someone has a bowel obstruction, where you kind of have a large dump of effluent that comes out through from the ostomy. And typically, what happens is people will notice that they have very liquidy output from their ostomy, and if you're measuring it, usually it's about 1 to 1.2 liters over 24 hours, occurring over multiple days. We really put someone at risk for dehydration. And when you're looking at the consistency of your ostomy, what I generally tell my patients is that it should resemble the consistency of applesauce or kind of split pea soup. The treatment for this, we generally kind of go from a step-up approach. So number one is you modify your diet, and certain foods can cause your ostomies to put out more, and certain foods can cause your ostomies to put out less. And what I always tell my patients, make sure you pick up some sort of electrolyte solution, whatever your favorite is, either Pedialyte, Gatorade, Powerade, basically anything that's not just your kind of plain tap water. So because you're losing quite a bit of electrolytes through that output as well. And then there are over-the-counter anti-diarrheal medications. So Imodium is a big one. Lomotil is not over-the-counter, but we often prescribe it for patients that have ostomies that are just very difficult to control in terms of their output. And so here, Katie is going to talk a little bit about signs of dehydration and how to manage.
Okay, so thank you so much, Dr. Yu, for all that information. So as an NSWOC, we have a commonly complication of high output ileostomies. So how do we manage? Well, obviously we want to assess the stool color, the consistency and the volume of the stool with each movement. We want to know how much is coming out versus how much is going in. Like Dr. Yu alluded to, we want to know what if the stool is really watery. Again, we want it more like an applesauce consistency. We want to look for and monitor for electrolyte losses. So some symptoms and signs of that might include headaches, fatigue, muscle cramping, and occasionally fainting or low blood pressure. We definitely want to make sure that patients are increasing their water intake to avoid dehydration. Obviously, if more is coming out of the ostomy, we want to make sure that people are replacing what's being lost through water, or like Dr. Yu alluded to, Gatorade, Pedialyte, whatever your favorite liquid of choice is. Speaking with your physician regarding avoiding or reducing medications that may increase your urination or may increase water loss. Obviously, if you're losing a lot of water from your ostomy, we don't want to be losing it from other places as well. We want to look at the other causes of infection, medication, obstructions. So some of the signs and symptoms of obstruction could be abdominal pain, really loud bowel sounds, a stoma that was previously working really well that is now no longer working. So those are all things that we need to be mindful of. And if we do see any of those signs and symptoms, that we want to make sure we're going to our doctor or even perhaps the emergency department just to make sure that we're getting it looked at. Considering dietary changes and maybe involving a dietitian. So making sure that, we have that low fiber, low residue food, that we are, eating food that has more water intake, that's replacing those electrolytes and those nutrients that we might be losing, as well as speaking with your physician regarding the use of medications that might help slow the bowel down, reduce your motility, so how quickly things move through the bowel, as well as the secretions that the bowel can produce.
Okay. So we'll move on here into the next most common ostomy complication, which is leaks or skin breakdown or skin excoriation. And this is much more common in small bowel stomas. And the reason for that is that, number one, the output is watery. So if it gets on the skin, it stays on the skin, it can macerate the skin. And the other thing that we need to keep in mind is that when the food that we're eating is going through the small bowel, there's still digestive enzymes that are active. And so the enzymes basically do their job regardless where you are. So the enzymes, their job is to break down protein and to break down fats and emulsify fats. And so if that gets on the skin and it stays on the skin, or if it's in frequent contact with the skin, the enzyme is going to break down the skin as well. And so the cause it can often be multifactorial. So I typically break it down into things like technical factors and then patient factors. So the technical factors are what we can control as surgeons in the operating room. And so things like avoiding a retracted stoma or a stoma that's inadequately brooked or everted, like I mentioned before, or a stoma that's in a very difficult location. So for example, in folds of the skin under, potentially an area that the patient can't see themselves. And so remember, everybody's abdomen looks a little bit different, right? And so in a stoma that's placed, that's retracted or inadequately everted, or in a difficult location that's difficult to see, and that's almost certainly going to guarantee that it's going to cause problems down the road. In terms of patient factors, and these are things that are out of control, unfortunately, from a surgical perspective. These are things like perhaps advanced age, cognitive impairment, neuropathy that makes patients less capable, I guess, in a sense, to recognize when they have a leak, or when it puts them at risk for having difficulty troubleshooting leaks at home. And it puts them at risk for just putting on a good seal around the appliance itself. And so because of all these different factors, typically the it's a self-perpetuating cycle where you have a poor fitting appliance or a difficulty fitting appliance leading to frequent leaks, and then leaks then lead to skin breakdown. And then once the skin even starts to break down even a little bit, patients can have lots of difficulty putting on the appliance because it hurts. They find that the appliance perhaps doesn't stick as well, and then it leads to more leaks and further skin breakdown. You can see how this kind of can snowball out of control very quickly. So for dealing with leaks and breakdowns, typically what I tell people is prevention is the best strategy, right? So this is where an NSWOC like Katie really helps me out for patients that are coming into the OR for a elective or a scheduled surgery. And so preoperative marking is very, very important, and I think it's very underutilized. And so basically what I do is I send all my patients to see Katie when they're having an elective surgery that involves or even can potentially involve making a stoma. And what she does is she has the kind of the time and the patience to look at these patients, have them, sitting, standing, and looking at their abdomen in multiple different positions to figure out where the best place is to bring out a stoma. And keep in mind that the reason why I don't know the best place to bring out a stoma is when I see the patient, when they're during surgery, they're lying flat and their belly is nice and flat, right? So I have no idea what the belly looks like when they're standing or sitting or, in whatever different position. And also remember, when patients come in to the operating room, they're not wearing their usual clothes either, right? They're usually in a surgical gown. And so I have no idea where their belt line sits, where their shirt goes to, and, whatever other perhaps jewelry they're wearing. I have no idea where any of that stuff is when they're in the operating room. And so, like I said, the prevention here is the best strategy. And so this is where Katie helps me out quite a bit with preoperative marking. And then there are certain adjuncts that Katie will touch on. If, for whatever reason, we just can't get the appliance to seal, there are adjuncts that we can use to try and make things a bit more tolerable, at least until the skin breakdown or the excoriation heals. And then perhaps it'll be easier to put on the appliance after that. And then in terms of surgical interventions for these, there are certainly things that we can do to try and make the ostomy better in terms of fitting the appliance around it. So revision of the ostomy, so perhaps pulling it out more, working it better or everting it better. Resiting the ostomy is certainly another option. So putting it in another place where it's more amenable to a better fitting appliance. And of course, always think about reversing an ostomy if it's causing problems. But of course, this is, as a lot of you may know, this is not always a possibility.
Okay, so as Dr. Yu was saying, prevention is obviously our number one tool that we use in stoma siting. So making sure that we have the right site for the right patient is huge. The second most important thing is really proper appliance selection. So we want to make sure that anybody with an ostomy, that they have a secure seal, that they have a realistic or predictable wear time, and then that they have enhanced quality of life. Those are really our goals whenever we're discussing ostomy care and just ostomy life in general. So we want to make sure that we select the proper appliances coming out of the gate. So we want to make sure that we're measuring our stoma every time we're putting on an appliance, especially in that first post-operative period, because sometimes the bowel, it's been manipulated, it's been traumatized, it's been pulled and prodded, it's going to be swollen. So it's going to change its shape over the next few weeks. So we need to make sure that we're properly sizing it so that until it's mature, that we're making sure that we actually have the proper fit and the proper size flange for those stomas. So within all of your ostomy product kits, you should have a measuring guide. And if you don't know how to use that, please speak to your nurse or your surgeon to really find out how to use that properly, because it is so important to make sure that you have the right size flange fitting around your stoma. You want the fit to be snug, but not too tight. Obviously, you don't want anything, causing pressure or any kind of pain on the stoma. but we really shouldn't be seeing any of that skin surrounding the stomal area once you have your flange on, because as Dr. Yu alluded to, the effluent or the stool that's coming out of the stoma is very, very acidic. And as soon as it sits on your skin, it's going to cause burning, it's going to cause itching, it's going to be uncomfortable. And then it's going to lead to a lot of other issues. So we really want to make sure that we have that proper fit and we have that proper seal. The next most important thing would be your skincare routine. You know, skincare is not just for your face. I always love to tell that to everyone. You need to make sure that you're cleansing your skin properly, especially, you know, the skin around your ostomy and your appliance, because if your skin's not cleansed and prepped, you're not going to get any hold and you're not going to be able to have success with your ostomy products. So you don't need anything fancy. You don't need anything, you know, with your lotions or your potions. Just plain paper towel or toilet paper. Just wet it with some water. It doesn't have to be sterile. Clean really well around the skin, very gently though, because it is sensitive skin. And then patting dry, making sure it's completely dry before you start putting any of your products or your flange on, because obviously if there's moisture there, that moisture is going to sit there, it's going to be trapped, and it's going to create some itching and some problems as well. Something else that Dr. You alluded to is there's different types of ostomy supplies. So if you do have problems with fit or comfort, there are different products that we do have available. There's barrier rings, there's protectant sprays, there's paste, there's powders. So you can always go to your local nurse, your local supply store, or contact your actual ostomy supplier for assistance on what products that they have to address your particular needs. There's so many different options that sometimes it can become very overwhelming knowing, what do I need? Do I need this? How much and how long do I need to use this? So having that expert advice and having somebody that you can go to kind of teach you the basics is crucial, especially for those early stages. With that being said, we always say less is more. You don't want to be going out of the gate with all of the products if you don't need it. If your skin is healthy, if your skin is intact, then you usually don't need anything more than probably a flange and a ring. If you start having problems though, or complications, that's when we start adding in these additional supplies. And it's really tailored to what you're experiencing and what your problem is at that time. And just because we use something and it worked once doesn't mean that we need to use it forever. Okay. The other thing too is if it's a really, you know, severe issue, please talk with your surgeon. If the skin's not improving, even though you're doing everything that you think is right and everything that you have been told to do, see if maybe there might be some surgical options for you to just really help get that skin back under control, or maybe they can connect you with somebody who has a little bit more expertise in that manner.
Okay. All right, so the next complication we'll talk about is something called mucocutaneous separation. It's basically our fancy way of saying there's a separation between the edge of the stoma and the skin. So this is kind of a pretty bad case of mucocutaneous separation here on the right side in this picture. So you can see the actual inside or the lining of the bowel is right here. And so you can see these sutures which have basically pulled through the bowel. And so this is the edge of the skin. So there's this big gap basically between the edge of the skin and the lining of the bowel. And so this typically, when something like this happens, no surgery is required because the bowel is still sitting right here and it's sitting above the abdominal wall, which is the most important thing when we're looking at a mucocutaneous separation. Because if the bowel has retracted back inside the abdomen, that's going to cause a problem because now you have stool basically seeping into the inside of the abdomen, and that can cause contamination and sepsis. And so that would be a surgical emergency. But if it's just the lining of the bowel that's pulled away from the skin edge, usually the management is conservative. So that's when we get our NSWOCs and like KD involved to try and basically help seal this and let it heal on its own. So the reason or the cause of this is often multifactorial. So again, we kind of break it down into technical factors and patient factors. So for the technical factors, it's usually tension, and sometimes if you're using incorrect sutures where they're cutting through the bowel, that can certainly cause this. In terms of patient factors, things like malnutrition, steroid use, which suppresses the immune system and compromises healing, right? Vascular paths, when they have issues with blood flow in the small vessels already, it certainly is not conducive to the bowel healing against the skin. And other things like diabetes and infection, these are all very common causes where it just basically prevents wound healing, and it puts patients at risk for mucocutaneous separation. So treatment here, again, you're going to hear me say this a lot, but prevention is key here. So again, if we're doing this in the elective scheduled setting, then I get almost all my patients to see Katie, have them marked preoperatively to make sure that we're choosing a site where there's minimal tension, and it's in a good place where the patients are able to see it, and they're able to use the appliance adequately. And there are lots of different adjuncts that Kenny will talk about in a little bit too, to try and help basically build up the edge so that the flange makes a good seal. And what we don't want is basically stool leaking into these gaps here. We don't want the appliance to not make an adequate seal. And then the kind of, again, the last resort here is, sometimes we need to look at revising the ostomy, perhaps putting it in a different site. And again, the best way to deal with an ostomy complication is always to reverse the ostomy if at all possible.
Okay, so how do you manage? So again, like Dr. Yu said, preoperative stoma marking is indispensable. It really helps highlight, the areas that are best for the patient. We look at how the patient moves, how they wear their clothes. We look at, any previous surgeries, any scarring, any creases or folds, anything that's going to cause complications in the abdomen, as well as where the stoma is sitting. In terms of actual marking, you want to make sure that you're placing the stoma within the abdominal muscles, because what that's going to do is it's going to give it stabilization. It's going to support it so that hopefully we don't run into these problems and these complications. New studies have shown that the use of convexity in the OR and afterwards ongoing use has actually reduced the risk of the separation of that skin surrounding the ostomy and the abdomen. The reason for this being is the way that the device is designed, it actually puts pressure around the stoma and pushes down on that skin, and it kind of pops the stoma out while also creating tension and making sure that the skin stays in place and that there's no pulling of those sutures while it's healing. Making sure that you have a healthy diet post-surgery is really important as well. Ensuring, again, I'm going to say this over and over again like a broken record, making sure that you have the proper size and the proper fit of your appliance. It doesn't matter if you have the right product. If you're not applying it properly, you're cutting your hole too big, cutting your hole too small, you're going to have complications. So making sure that you are measuring and fitting your appliance to your stoma. Focusing on your skin hygiene protection. So we, don't need all the fancy wipes and different things. Simple water and toilet paper works fine. If you want to use like a skin barrier or some sort of protective film on your skin, that is okay too. So what that does is it kind of creates a layer between your skin and the sticky part of the flange, so that when the adhesive sticks to your skin, it's actually sticking to the barrier. So when you're removing it, it's removing the barrier opposed to your actual skin. Making sure that, if you need to use a barrier ring or if you need to use any kind of skin protectant, that you're having that available to you and having those conversations with a nurse specialized in ostomy or with your appliance specialist to make sure that you have access to those and that you're using them properly. Wound care as needed. So unfortunately, a lot of times there are instances where we do get a little bit of separation in that area where the stoma comes through the skin. Most times it heals without much needed, but sometimes you do need to have specialized packing, wound care nurses coming to the home and making sure that things are healing on the right path. Other things as well to consider is, specialized wound care if you have open rashes, weeping, any kind of ulcerations or tears in the skin, because obviously if you have any moisture or any, decreased integrity of your skin, you're not going to be able to stick anything to it. You can't try and stick something to a sticky, wet surface. It's not going to work as well as if that surface was nice and dry. So, your nurses and your physicians can definitely help you troubleshoot that if you need it. Involving your surgical team and your NSWOCs early on, I think that's invaluable, making sure that, everybody has the right education, that you have the understanding and the confidence to address these issues, and also knowing, okay, I know something's wrong, who can I reach out to? I think that's a really big advantage, especially having, a good relationship with your team, making sure that they're in your corner. As well as surgical intervention. As Dr. Yu said, the best solution sometimes is just to reverse it or to move it to a new spot where hopefully you're not going to have the same complications. So working with your surgeon and, trying to find the best solution that fits for you and fits for your lifestyle.
Okay. All right. So two more common complications. So these are more so for patients that have had perhaps their ostomy for a little bit longer. So number one is prolapse. So this can really occur with any kind of ostomy or stoma. Typically you find that the small bowel is a bit more mobile, so it tends to move around a little bit more even inside the abdomen. And so it's a bit more common in terms of having an ileostomy prolapse rather than a colostomy. And usually it does not affect function or pouching to a great degree, but certainly it can if it gets to a very large prolapse, and like seen in the picture on the right side here. And so what I generally tell my patients when they start to see a prolapse is that it's much more traumatic than it actually is. And so typically I tell them, yeah, you can go ahead and reduce it yourself or push it back in yourself. You just have to know how to do it and be comfortable with doing it. And so basically to reduce a prolapse, you can kind of just apply gentle, steady pressure, and basically just kind of push the bowel back into the abdomen, and pushing it kind of from the outside towards the inside. So kind of the opposite way that it's prolapsing. And so typically for a prolapse, we don't usually revise the stoma or reverse it, unless people are seeing significant issues with pouching the appliance or leakage, things like that. And so again, for any ostomy complication, the best treatment is to just reverse the stoma or reverse the ostomy. Again, not always possible, but if we need to, certainly we do revise stomas and basically just reduce or repair the prolapse surgically. But again, the concern here is that it certainly can prolapse again even after a repair, right? So recurrence is a common issue with a prolapse stoma. And then the other one is a parastomal hernia. And again, this is very common, particularly in patients that have had stomas for perhaps a little bit longer. And so this is what it looks like. So this is showing basically a piece of colon that's coming out through the skin, but this can occur with any type of stoma. And the reason why this happens is that we're creating kind of an artificial opening through the abdominal wall. So we're making this area weak on purpose, and we're creating a hole through it. And so the body's natural tendency is to basically push more things through there. And of course, what's inside the bowel or what's inside the abdomen is more bowel, right? So typically loose bowel can get caught in the stoma. And this can occur with any type of stoma. And it can certainly cause obstructions. So you can imagine there's a piece of bowel that's stuck in the hernia itself. It can be prone to obstructions. It can certainly cause a bulge, which of course changes the contour of the abdomen, which can then result in difficulty with pouching. So here again, how we treat these stomas is again based on how symptomatic they are and what kind of problems they're having. We always go from least invasive to most invasive. And so this is when we get our NSWOCs involved. We look at can we give them a different type of appliance, use different adjuncts like Katie had mentioned previously. And then if it doesn't work, then we look into the repair or reversing the stoma. And so this is what a parastomal hernia looks like. It's obviously not always a perfectly round kind of baseball size in the picture shown here, but this kind of generally gives you the idea that there's a bulge around the stoma itself. And so when we do repair hernias around the stoma, this is typically what we do. So this is basically looking at the stoma from the inside of the abdomen here. And so these are two kind of the more common approaches where you put a piece of mesh to basically brace the bowel against the abdominal wall. And this is, of course, like after we pull the loops of bowel out of the hernia. So we put this piece of mesh here either around or kind of underneath the bowel to give it a kind of extra strength and reinforcements.
Okay, so how do we manage? So with the stomal herniations, as Dr. Yu mentioned, reducing the abdominal pressure is really key here. So we want to look at, supportive abdominal garments to support those muscles. There's different techniques that you can use, but really those belts and those abdominal binders that are really going to give you some extra support to kind of keep things in place and where they're supposed to be. Focusing on re-strengthening the abdominal wall. So usually what happens with herniations is there's a defect or a weakness in the abdominal wall, and obviously the bowel is pushing on it. So if we can restore that strength to that abdominal muscle, we can definitely minimize the herniation. So this can be done through physiotherapy, working with specifically specialized trained therapists that can actually focus on those abdominal muscles and focus on the proper exercising and strengthening techniques. We want to make sure that we're reducing weight, maintaining a healthy diet, because obviously additional weight, especially on the abdominal wall, can increase your risk of herniations and increase the extent of it. You want to avoid constipation, any straining, lifting anything heavy. Again, that puts increased pressure on your abdominal wall, which it will worsen your stomal herniation. Of course, consider surgical management if it is really affecting your quality of life, talking with your surgeon, seeing what your best options are. In regards to the prolapse, again, as Dr. Yu said, usually we don't really want to do too much with this unless it's causing a complication. The best thing to do is just teaching your patients that when this happens, making sure that you're laying down, that you're relaxing. A lot of times the stomal prolapse will correct itself. Once you start relaxing and doing your deep breathing, it will retract back into its position. There are supportive devices available, such as hernia belts, stoma guards, different things to help put pressure on that area so it keeps things inside where it needs to be rather than telescoping out. Again, continuous gentle pressure, so just manipulating the prolapse and pushing it gently back into the bowel. You don't want to do it too hard. You don't want to cause trauma, but you can kind of manipulate it and guide it back in until it's at a normal shape. Other methods that have been really successful for reducing stomal prolapses are cold washcloths. It causes constriction and it causes things to shrink. Or believe it or not, sugar application, putting some sugar, sprinkling some table sugar on your prolapses will actually cause it to shrink back in. Proper appliance selection. So again, you need to have a proper appliance to accommodate the changing size of your stoma. Typically my patients find that, the one-piece larger bags are a little bit better for them. Making sure that you're measuring your stoma when you're laying down as well as when you're up and about, and maybe when it's prolapse, so you can see the change in the size so that you can adjust your flange size to accommodate the extra size. Making sure that you're always looking at the size, the color, and the output. If any one of those things changes, please speak to your physician or to your nurse to make sure that it's not something that, needs to be handled emergently. And then, of course, if it's something that's really affecting your quality of life or affecting your stoma health or function, talk to your surgeon about potential surgical management. Sorry, this is me again. Okay, so community support. So depending where you are in Canada, you'll have different kind of supports available in your community. Here in Ontario, we have Ontario Health at Home, which is our overseeing body for community care services. So they're a great resource. They have nursing clinics available for patients that are ambulatory. They have in-home nurses available. They have NSWOCs that can actually come to the home or come to the clinics and provide education. We also have local ostomy clinics that are held throughout the province. So check with your province and check with your area to see if you have clinics available. Usually they're held once a month, and they, have specialists that come in, product specialists, osteomates, NSWOCs that provide education. If there is something local or online that you can access, that's great. There's a lot of ostomy support groups that are available in person and online, depending on where you live and what's available. So again, look for those resources. I'm sure if you don't have any resources, you can always reach out to your ostomy nurse or your surgeon who probably know about local resources available. NSWOC Canada, they have a list of all the NSWOCs who are registered through the academy. So you can find someone in your local area, see if, you can reach out to them for assistance, for guidance. Maybe, if they don't know how to support you, they might know someone to get in contact with to help, as well as your education resources. So there's online videos, training modules. Mostly every big ostomy company has these online videos and education sessions available. Ostomy Canada is a great website as well to go on. They have all the different educational resources as well available. And as always, if you don't know where to go or what to look for, talk to your nursing team, talk to, your local osteomate support group, talk to your surgeon. Somebody would be able to point you in the right direction.
All right, so that is the end of our presentation. I'm going to stop sharing my screen here.
Whoops. There we go. Now I'm on. Sorry about that. Thank you both for such a fantastic presentation and going through so many of these. I know we had lots of questions from the beginning, and you've answered so many already, which is great. And as you were speaking there, Katie, I was just putting in the announcements area or the Q&A area, the link to the Find an Ostomy Canada chapter or peer support group. I put that Find an NSWOC tool in as well. So if you're online with us here, if you click on your Q&A button, you should see those links pop up if you want to access those there. So let's get to a few here. We've got a good amount of time. So let's maybe chat about this one. Some people were asking whether it's okay to sleep on your stomach, or would that damage the stoma or increase the risk of complications if you were to lay down on your stomach?
Dr. Yu, do you want to take this one?
Go ahead? Sure, yeah, I can start. Yeah, so I mean, I generally tell my patients, like, there's not a lot you can do in your kind of usual daily activity to hurt the ostomy. Even in the acute setting, like it's difficult to cause any harm to the ostomy itself, and particularly like once things are healed up. If a prolapse or a stoma is going to happen, it typically is going to happen regardless of what you do. So I certainly wouldn't let these fears of complications prevent you from doing your usual activities. If anything, we encourage you to do your usual activities, stay as active as possible, just so that you're not running into other issues with potentially deconditioning after the surgery. And I certainly think that's a great question, but I don't think there's any high quality evidence in terms of suggesting, well, sleeping in your stomach can injure the ostomy. Probably not. That would be highly unusual, and can perhaps reduce the risk of a parastomal hernia. Again, I don't think there's any convincing evidence one way or the other. So I would generally tell people, do whatever it is you're comfortable in terms of your sitting position, whatever you prefer. If these complications are going to happen, they typically happen kind of regardless of what you do, aside from kind of some of the modifiable risk factors that we kind of covered in the presentation.
Yeah, I agree. I think, if it hurts, don't do it. Obviously, if you're having issues with your pouching or with your seal from sitting or laying in a certain position, then we can work with different products and different techniques to kind of help optimize your comfort. Obviously, you need to do what's most comfortable for you, and if that's the best way you sleep, then we want to be able to promote that.
Absolutely. Well, we'll see if we can get through a few more questions here. I know we got one that came in recently. In specific situations, some people might be looking at using laxatives. Are stimulant laxatives like Senna ever appropriate for someone living with an ostomy, or is that generally avoided due to concerns like their output and dehydration in general? Is that more of a, concern with blockages? When might this be a good option? We'll start with Katie here. We'll switch it up.
Okay. Obviously, I'm going to say again, anytime you're introducing medications or anything that's going to change your bowel habits, please do so with a conversation with your physician or with your nurse. Like, don't do anything without speaking with them. In my practice, there is a place for laxatives, especially if we're trying to soften the stool. We're trying to get back to that optimal consistency. But again, it's something that we want to make sure that we're doing in conjunction with the overall picture, and we're doing it with a physician overseeing everything. Most importantly, we want to address the reason what's causing the problem. So is it that we're not drinking enough water? Is it that we're having too high fiber foods? If we're not having enough of those leafy greens? Are we eating foods that really are prone to causing obstructions? Can we modify our diet or our exercise level to address the issue rather than just, continuously using medication?
Yeah, thank you for covering that. And I'm just conscious of time, so we'll see if I can go through a few more here. We had quite a few questions beforehand, and another one I see coming on now about concerns about showering either with an appliance on. Is there any concerns of it falling off or losing its adherence? And then I guess separately to that, is it safe to shower without my appliance on?
Yeah, so I tell my patients, you do what makes you feel most comfortable. A lot of the appliances out there are waterproof. They're designed to kind of withstand water. So if you feel most comfortable showering with your appliance on, definitely shower with it on. If you find after your shower that your appliance isn't holding as well, or you're having any leaks or any problems, definitely change it. If you feel comfortable showering without your appliance on, it's great for the skin, making sure that you're not scrubbing or using any lotions or potions around your stoma or around that sensitive area. And then making sure that before you reapply your appliance, you're drying your skin really well, you're preparing it, and making sure that you have that really good hold. But honestly, in my practice, I tell people do what makes you most comfortable and what you feel is best for you. But I'll let Dr. Yu chime in.
Yeah, so this is a very common question that I get from my patients, right? And so I generally tell patients, well, like with a new ostomy, treat it like any other incision, because you do have sutures around the stoma and basically holding it to the skin. But again, with these sutures, typically I tell people, 1 or 2 days after the surgery, you can start showering, just pat dry afterwards. Yeah, and like Katie said, whether you shower with or without the appliance, doesn't make a huge difference from kind of the surgical side of things. And you certainly won't injure the bowel by having water run over it, right? Keep in mind that there's water inside the bowel at all times, so you're not going to hurt anything by having water run over the bowel.
Mm-hmm.
And really, I guess the concern here would be potentially, doing something with the sutures during a shower or perhaps more during a bath. And so I generally tell people, well, maybe avoid baths for a couple of weeks after the surgery, just to let everything seal up, let the skin close against the inside of the bowel. But again, certainly you won't hurt anything by just having water run over the stoma itself. And I tell people as well, like if you're trying to save the flange, right? So like if you have a new flange on, and you want to take a shower or have a bath, yeah, I generally tell people just go ahead and tape something that's waterproof around the flange,
Hmm.
so that you don't get it wet during the shower or the bath, and kind of take off. I just tell people just put it, even like a piece of saran wrap is totally fine, and then just take it off afterwards, so that you're not going through your flanges more quickly than you would like. But
There
that's
are-
really more from the practical side of things.
Yeah, and there are also like shower bags that you can purchase for that reason too, if you're so inclined. I'm sure Amazon or a specialty store would have that.
Absolutely. And Doctor, if I can ask you as well here, we have a lot of questions have come in both now and previously, and even just anecdotally from my side. Are you familiar with or would you have any advice for someone who's concerned about corrective surgery for peristomal hernias? Is it pretty commonplace? Is it usually, looking at conservative management as the main line of defense versus going to surgery? What are some of those people who are having those thoughts right now? What would you maybe say to them?
Yeah, so again, a lot of my patients ask the same thing, right? Is that, that I have a lot of patients that have permanent ostomies. So again, like we talked about, in the presentation, I generally tell them, well, it's a bit of a step up approach, right? So, we never want to just jump into surgery the minute we see a stoma, right? And so I guess the question is, well, what symptoms are you having from the stoma? Like, how is it affecting your quality of life? And that's the biggest question that we have to ask ourselves when we're looking at potentially an invasive surgery to fix a benign problem. And so if somebody is suffering with a big peristomal hernia, it's making them go through lots and lots of appliances, and it's taking a financial toll on them. It's affecting their quality of life. Certainly, I think that would be a great candidate to at least have a discussion for a repair of a peristomal hernia. But every once in a while, we see, perhaps just a little bit of bowel sneaking through, and the patients may not even notice it themselves, because sometimes we do a CT scan, and it shows the hernia on the scan, but really it's not appreciated on our clinical. So, those are typically what we call like subclinical hernias. And generally, I say, well, in that case, if you're not having any symptoms like pain or obstructions, generally we prefer to leave those alone, because again, the risk of surgery is just not worth the benefit at that point.
For touching on that. I think that'll hopefully give some reassurance to a lot of people who are thinking about that. One question I'm trying to cover, kind of a broader topic here is, and I know we're just over time, so we'll see if we can get to one, maybe last one here. Can you just remind some people about maybe what the common causes of bleeding might be, either just on or around the stoma, and when someone should be concerned about the amount of blood? Someone's even just mentioning, sometimes when changing my appliance, I wipe very carefully around the stoma, but a very small amount of blood from touching the stoma. When would that maybe be a concern, versus maybe even if we're talking about the skin around there, when are we looking for when are we identifying that this is a problem now? And maybe again,
You want to
either
go ahead
whoever
first?
wants to go first, but feel free, Katie, if you want to start.
Sure. So again, some questions, right? How troublesome is it to you? Is it painful? How long has it been going on? Again, what products are we using? So are we using baby wipes? Are we using anything with scents? Or do you have a proper fitting flange? Are you using any of those, adjuvant supplies or products that can kind of help with skin soothing and skin comfort? So I'm thinking like barrier rings, barrier spray, any films. Sometimes there's lotions or medications you can use. So that skin around the stoma, it's sensitive. It's skin. So you want to be gentle. You don't need anything other than just water and toilet paper. And if you're finding that it's ongoing or it's worsening, then definitely it's something that you should be bringing up with your surgeon or bringing up with your doctor or nurse, whoever you're most connected with. But if it's something that's just small, because maybe you're wiping too close to the stoma itself, maybe you are a little bit too rough when you're trying to clean, especially sometimes the stool can get really sticky. So try maybe just laying like a wet piece of toilet paper on the area for a couple minutes and letting it kind of soak off rather than trying to scrub at it, because obviously the more irritation, the more friction, it's going to cause more trauma to the skin.
Thank you. And maybe Doctor, you for the stoma itself, is there any concerns if there's a little bit of blood once in a while? Is that something normal, or no, we should be looking at that?
Yeah, so again, it's like a very common issue with my patients that come in and say, look, I see some blood every once in a while. And so I think here the biggest question is, well, wait, where is the blood coming from? Like, are we sure that it's from around the edge of the stoma and not from the inside of the bowel, right? Because I think that's very just a different treatment algorithm that we kind of go down. And so that's the first step is a good thorough examination of the stoma. And what does it look like? What does the actual mucosa or the lining of the bowel look like? Does it appear irritated? Does it have, perhaps like cuts on it from the actual appliance itself? Or do we think there's something further in, perhaps like upstream of where the stoma is, and it's coming through the stoma, and patients are mistakenly thinking that it's from the lining or the stoma itself, right? So again, I'm digressing a little bit, but that's always the number one issue to figure out when someone comes and sees me in clinic. Now, if the trouble is actually there's bleeding from the lining of the bowel or from the skin, that's also a very common issue. And the vast majority of the time is of very little concern in terms of kind of how serious it is. Because like you described in kind of the question, it's intermittent, it's very low volume, and it typically resolves on its own without needing a whole lot of intervention. So I generally tell people, like, yeah, if you see a little bit of blood when you're wiping, changing the appliance, I generally don't get too fussed about it. Now I do caution the patients that when they're cutting the appliance, especially if someone has a new stoma and they're not quite used to cutting the appliance, it can be like you can result in kind of a bit of a jagged edge when you're cutting the actual appliance and the flange, right? And so I tell people that the inside of the bowel is very friable, it's very sensitive, and even just a little bit of abrasion can cause it to bleed. And so I generally hope that's one of the more common reasons that if they're the appliance is the sides of the flange is coming a little bit too close to the inside of the bowel, it can certainly cause irritation and cause small lacerations on the inside. But again, it's oftentimes it just resolves on its own. And then I just tell my patients to perhaps cut a little bit bigger without risk of leaks. But it's very unusual for us to see patients come in with a serious life-threatening bleed needing transfusions or any of that any of those kind of severe issues.
Yeah, well, thank you for even just for providing the reassurance on that side. I think it's really appreciated. I know we're at the end here, so I want to thank you both for again doing this. I see one comment here from someone who's had an ostomy for 11 years and learned a lot tonight. So thank you so much. And I think it is always a reminder that it doesn't matter if you got it last week or if you've had an ostomy for half of your life. It's always good to learn a little bit more, and there's always something you can learn from webinars like these. So as I'm thanking you, I also want to remind everybody else in the conversation here that we do have a number of past webinars as well. So if your question today maybe was about gas and odor and bloating, maybe it was some more information about parastomal hernia, maybe it's about peristomal skin complications, we do have a library of some others, including with Hollister as well. And so do take a chance at looking at some of those webinars too for more information. But other than that, I want to say thank you for being here, both of you, and taking the time. And thank you to Hollister for making today's educational webinar possible. We hope everybody has a great rest of the evening, and we'll hope to see you at the next webinar as well.